about yet another important topic, that is anti-tubercular therapy. This is a very important topic. Today we are going to discuss about the newer classification of the anti-tubercular drugs, the drugs, its mode of action, the side effects and newer drugs. Now let us see the classification first. So now ADT are classified into 5 groups: Group 1, Group 2, Group 3, Group 4 and Group 5. As you know, Group 1 are first line oral drugs, comprising of Isoniazid, Rifampicin, pyrazinamide and Tubercular. Group 2 are injectable forms, usually capreomycin, kanamycin, amikacin and in some streptomycin. Group 3 are fluoroquinolones, levofloxacin, ofloxacin, moxifloxacin and gatifloxacin. And Group 4 are second line oral drugs. These comprises of Cyclo Siddhant, ethionamide, prothionamide, para-amino-salicylic acid. Group 5, these are miscellaneous drug or doubtful efficacy, unknown efficacy. Usually clarithromycin, high-dose INH, amoxiclav, clofazimine, linezolid. As of now, anti-tubercular therapy is divided into 5 groups: Group 1, Group 2, Group 3, Group 4 and Group 5. Why are we dividing this into groups? Because due to emergence of MDR tuberculosis. Now let us see what is MDR tuberculosis. MDR tuberculosis is multi-drug resistant tuberculosis. The bacilli should be resistant to H and R. If it is resistant to Isoniazid and Rifampicin, it can be termed as MDR, with or without resistance to other drugs. Suppose if the drug is only resistant to Isoniazid, it is called monodrug resistance. If it is only resistant to pyrazinamide, it is monodrug resistant. Suppose if it is resistant to H and Z, 2 drugs, it is not multi-drug resistance, it is polydrug resistance. Suppose it is resistant to Z and E, it is also polydrug resistance, not multi-drug resistance. To say it is multi-drug resistance, it has to be resistant to both Isoniazid and Rifampicin. Now coming to the next group, what is XDR? It is extensively drug resistant. It is nothing but MDR plus. It is resistant to Isoniazid, Rifampicin. From the second group, any one injectable and one fluoroquinolone. So one or more injectable and one fluoroquinolone. So from this, any one or more, and from this, any one drug. So this is XDR tuberculosis. So to classify the types of tuberculosis, drugs are also classified into different groups, and these are very important because their side effects are also being asked nowadays. Now first, before learning about the different actions of anti-tubercular drugs, now let us see some few points about bacilli. So tubercular bacilli are usually rapidly dividing bacilli, slow or intermittently dividing bacilli, and the third one is dormant bacilli. According to the present concept, no drug acts against dormant bacilli. Regarding slow or intermittent dividing bacilli, sometimes called as persistars, sometimes called as subdormant bacilli, Rifampicin and pyrazinamide act very well. Against rapidly dividing bacilli, usually H, R, Z, E, S. All the drugs usually act against rapidly dividing bacilli, but it is the slow or intermittently dividing bacilli that causes relapse, and usually they drugs like rifampicin and pyrazinamide act very well on this. So that's why rifampicin and pyrazinamide act on slow intermittently dividing bacilli very well and clears the total cavity without any bacilli. That's why it is having sterilizing activity. This is the concept behind sterilizing activity, because it is able to act also on the slow and intermittently dividing bacilli. Now let us see something about ATT. First thing, all are bactericidal first line drugs except ethambutol. Ethambutol is usually bacteristatic. It is also least potent. Most common hepatotoxic is usually INH. Most potent first line drug, I will go with rifampicin. Drug acting very well in acidic and intracellular environment will be pyrazinamide. Drug which acts both in intracellular and extracellular, it will be rifampicin. Drug based on rapidly dividing and intermittently dividing, it will be rifampicin followed by pyrazinamide. Drug with very severe hepatotoxicity, it will be pyrazinamide, and drugs with sterilizing activity, it will be rifampicin and pyrazinamide. Another concept here to remember is, there is one question asked, drug with high early bactericidal activity. What is this early bactericidal activity? Suppose there are 1000 bacilli. If you give a drug for 2 days duration, among rifampicin, isoniazid, ethambutol and pyrazinamide, which destroys majority of bacilli, that is early bactericidal. Out of 1000 bacilli, if you give INH, round about 900 will be destroyed. 800 by pyrazinamide and rifampicin, and 600 by ethambutol and streptomycin. So it indicates that INH has very high initial bactericidal activity. So that is INH. Drug that can cause blindness. Remember ethambutol. For E for eye. It affects eye and it can decrease the visual acuity. Usually blindness caused by ethambutol or decreased visual acuity by ethambutol is reversible. If it decreases visual acuity, it can be reversed. And another thing to remember here is, drugs acting on only extracellular will be streptomycin, and in alkaline medium also streptomycin can work well. Drug acting both on extracellular and intracellular, it will be rifampicin. Important thing to remember is, pyrazinamide acts very well on intracellular acidic environment, whereas rifampicin will act on intracellular organism, extracellular organism. Rifampicin can act in acidic environment and it can also act in alkaline environment. So that is why we consider rifampicin as the most potent first line drug. Now coming to each drug in detail. First one is INH, also called Isoniazid. Mechanism of action is catalase, peroxidase, CAT-G. So these are the things. Isoniazid is a prodrug. When enters into the bacilli, by catalase and peroxidase and CATG mechanism, it is converted into the active form, which interferes in mycolic acid synthesis. What you have to remember is it decreases the cell wall synthesis, or its mode of action is through cell wall synthesis inhibition. One more thing important to remember is there will be fast accelerators and slow accelerators. Side effects: as it interferes with pyridoxine metabolism, it will cause peripheral neuropathy, and in severe cases it can cause psychosis, convulsions, that is neuropsychiatric manifestations. Here for prophylaxis 10 mg is given. For treatment of this episode 100 mg is given. Also it causes hepatitis. Most common side effect is increased elevated transaminases, and other side effects include rash, pellagra, SLE, anemia. It can also cause optic neuritis, and finally gynecomastia. 1 in 10 power 6 bacilli are innately resistant to INH, and resistance is through INHA gene. So remember about INH, the mechanism of action, the presence of fast accelerators and slow accelerators, the side effects: why peripheral neuropathy, psychosis, convulsions, and hepatitis. And also another side effect you have to remember is INH can also cause an entity called shoulder hand syndrome, characterized by arthralgia. This is important. Shoulder hand syndrome, it can also cause arthralgia. Dose of INH is usually 4 to 6 mg per kg. Coming to the next drug, another important drug, Rifampicin. The mechanism of action is through DNA dependent RNA polymerase. It decreases nucleic acid synthesis. It can induce CYP450. It decreases dose of OCPs. So it decreases the level of OCPs, decreases level of warfarins, sulfonylureas, NNRTAs like nevirapine, protease inhibitors, anticonvulsants, digoxin, etc. That's why these doses should be titrated accordingly when given with rifampicin. Side effects include mainly abdominal syndrome characterized by nausea, vomiting, diarrhea, cutaneous syndrome, respiratory syndrome, flu-like syndrome. So this is very, very important. Usually flu-like syndrome is caused by intermittent regimen. When you convert into daily regimen, this may not occur. Caused by intermittent regimen. It is characterized by fever and myalgias. Respiratory symptom: cough, shortness of breath, and fever. Another important thing is they can precipitate purpura, thrombocytopenia, result in shock, hemolysis or hemolytic anemia, and finally can cause acute renal failure. It is also known to cause Redman syndrome, orange red urine, Dose of rifampicin is 8 to 12 mg per kg. Resistance is through Rifampicin. Other uses of rifampicin. It is used in prophylaxis of meningococcal and H influenza meningitis. The dose is 600 mg BD 2 days. Also used in leprosy, staphylococcal endocarditis, osteomyelitis, in some case of trachoma, and also in some case of brucella. So these are the side effects of rifampicin. Remember, flu-like syndrome, it is not due to daily regimen, it is due to intermittent. It can cause acute renal failure. Drug precipitating acute renal failure is rifampicin. Red man syndrome, and the resistance is through Rifampicin. The dose and 1 in 10 power 7 bacilli can be resistant to rifampicin. And it can also be used in staphylococcal endocarditis, osteomyelitis, and the dose also has to be remembered. Coming to the next drug, that is pyrazinamide. It also inhibits mycolic acid synthesis. There is a new action by tmRNA, transfer RNA, so it decreases the cell viability. And very important to remember is pyrazinamide in some cases will cause very severe hepatotoxicity. If hepatotoxicity is documented due to pyrazinamide, never try to re-challenge it again. Most common side effect will be elevated urate levels, that is hyperuricemia, can cause arthralgia. Very rarely it can cause gout. Other side effects like rash and hyperglycemia. Resistance can be mediated to PNCA gene. The dose usually is 20 to 30 mg per kg. And next thing is ethambutol. Arabinosyl transferase inhibition inhibits cell wall synthesis. It is bacteriostatic, renal excretion, caution in renal failure. Remember, ethambutol is the thing only excreted by kidney, others all through liver. So caution in renal failure. E for eye, affects eye. It will cause optic neuritis, retrobulbar type, color blindness, that is red-green blindness, patient, so green can't be seen. Remember, green not seen. So it is red-green blindness and decreased visual acuity. It is reversible within 1 year, and also it can cause hyperuricemia. So these are the side effects of ethambutol in the doses of 15 to 20 mg per kg. Coming to next drug, streptomycin. It can penetrate inflamed meninges and pleura. Remember, pyrazinamide can very well penetrate the meninges and pleura, but for streptomycin to penetrate, it requires inflamed meninges and pleura. So that's why it is very helpful in meningitis cases. It causes nephrotoxicity, not used in renal failure. it causes ototoxicity, it causes fetal eighth nerve damage. That's why not used in pregnancy, not used in myasthenia gravis as it increases neuromuscular blockade. Given in doses 15 mg per kg, usually started in category 2. We'll discuss regarding different types of category 1, category 2 and RNTCP in the next lecture. Now coming to other drugs, that is second line drugs. Very important thing is Cyclo Siddhant. This is bacteriostatic. It interferes in cell wall synthesis. And the most important thing is it can cause neuropsychiatric manifestations resulting in suicidal tendencies, convulsions and psychosis. So that's why a psychiatrist has to be there when you are prescribing Cyclo Siddhant, because it will cause suicidal tendencies. It can also cause nephrotoxicity. Coming to next drug, ethionamide. Like INH, it can cause psychosis, it can cause optic neuritis, it can cause gynecomastia, and it can also cause hepatitis. And there is some amount of photophobia. These are the side effects of ethionamide. This is important. Remember suicidal tendencies and remember gynecomastia. Coming to next drug, that is para-amino salicylic acid. It inhibits or interferes folic acid synthesis or metabolism. The side effects are, first thing, hematological abnormalities like megaloblastic anemia, hypothyroidism, hepatitis, hypersensitivity reaction and hypokalemia. You can remember it as HS. Hematological abnormalities, hypothyroid, hypokalemia and hypersensitivity. Coming to next important drug, that is thiazidone. Very important to remember is it can cause SJS in HIV infected patients, and it can also cause aplastic anemia, thrombocytopenia. We have discussed in second line drugs important side effects of Cyclo Siddhant, ethionamide, PAS and thiazidone, and other drugs like fluoroquinolones, aminoglycosides. The side effects are same as their respective classes. Now ATT causing psychosis, ATT that can cause convulsions. One is INH, in second line drugs fluoroquinolone, Cyclo Siddhant and ethionamide. Remember, in second line drugs, drugs mainly causing hepatitis are PAS and ethionamide. Other drugs like aminoglycoside, Cyclo Siddhant, they all are nephrotoxic. Coming to Rifampicin derivatives, Rifampicin, it is useful in traveler's diarrhea. Side effect, there will be encephalopathy, sometimes hepatic encephalopathy. And Rifampicin, it has better half-life, decreased drug interactions with protease inhibitor. That's why when giving with protease inhibitors, rifampicin can be replaced by rifampicin, And another thing is it has better action against non-tuberculous mycobacterium and MAC. So that is Mycobacterium avium complex. Now coming to newer drugs. One is delaminide, sutizolid or linezolid, PA and OPC compound. So this is OPC 67683. And recently approved, US FDA approved, very important one will be diarylquinolone or TMC 207 or bedaquiline or sulfuro. So it is used in MDR-TB. The mechanism of action is ATP synthetase inhibition, and specific side effect will be QT prolongation. So friends, we have discussed about different class of anti-tubercular drugs, their doses, their mechanism of action, their side effects, and also the newer drugs and side effects of second line drugs. Thank you friends.